Hi, my name's Tori and I wish I knew more about blood products.
Hi, my name's Letitia. I wish I knew more about taking care of myself when starting shift work.
Hi, my name is Lydia. I wish I would know more about how to work as in a team and solve conflict.
Hello, welcome to 5 Things, the nursing podcast from the Royal Brisbane and Women's Hospital. My name is Liz Crow.
I'm Jesse Spur, and this is a podcast by, for, and with the amazing nurses and health professionals in our corner of the world. We hope to connect with a global community as we move from surviving to thriving. Welcome to 5 Things.
Hello, my name is Liz Crow.
And I'm Jesse Spur.
Welcome to another episode of 5 Things. And today we are welcoming Dr Leisa Turkington, who is the Senior Speech Pathologist and Clinical Researcher here at the Royal Brisbane and Women's Hospital. And she's come to talk to us today about disordered swallowing.
Thank you for having me.
I'm a little bit nervous of having to record speaking in front of a speech pathologist, I must admit. I'm watching my words and my...
We can do online marking if you want.
Be careful to enunciate today.
Now, we'd love to hear your origin story. We've had a lot of different health professionals on, but not a speech pathologist yet. And also picking up on the fact that you've done your PhD, I imagine there's some specialisation and depth of interest in there too.
Yeah, I think I've been working as a speech pathologist since 1992. And my first role was back near my family property in Toowoomba. I grew up on a beef property. I went to Sydney Uni on an academic program because they provided accommodation. So I went from a cattle property to Sydney Uni. So, boy, the first year wasn't a lot of study, but we'll move along from that. After a few years, I did like a lot of Australians and went backpacking and went with a very dear OT friend. And 13 years later, I came back with a husband and 2 children from the UK, which my mother was relieved about. But during the time over there, I did my master's in neurogenic disorders, worked at 2 quaternary centres, and have spent most of my life looking at neurogenic acquired disorders within a hospital setting, and predominantly looking at video fluoroscopy, so like X-ray swallow or modified barium swallow, we used to call it, is sort of my key research and teaching area.
I think lots of people really underestimate how scientific and how anatomical speech pathology is to study and then work as a clinician.
Yes. And you need to know, depending on what area you go into, but if you become a head and neck speechy or you become a neurogenic speechy, we're quite nerdy about cranial nerves and about all the muscles involved with swallowing.
Yeah. All right, so let's jump into it. Our number 1 is, what is disordered swallowing?
So that is dysphagia, and with emphasis on the G. There's a lot of, we just were talking previously with some nursing stuff about how confusing our world is and all the labels we use. And I think Jesse referred to a reminder with regards to that.
Yeah, I always just think G for gut. So I think about the swallowing to the gut, and S for speech.
Yes. So when you're thinking dysphagia, we've got a G. And if you're talking aphasia, and you've got an S, that is sort of any of the language disorders. And we tend to... that's probably a good reminder, and it's still confusing if you're not in our space all the time. But disordered swallowing, dysphagia, can happen for lots of different reasons, really, from pediatric dysphagia right through to dysphagia because you're elderly or older and you've got other sickness that sort of makes your system unravel. And we can talk a little bit more about that as we go along.
All right, so dysphagia. I'm going to say that all the way through with that pronounced G for gut.
10 out of 10.
So your number 2 is, how do you actually assess for dysphagia?
So in our setting, in an acute setting, we do a number of things to make a clinical swallow evaluation good at the bedside. Probably as a neurogenic speech pathologist, I will talk about this slightly differently to an oncology speech pathologist. But my first starting block would be looking at the history of the presenting condition, why the person has come in and why the medical team or other teams are worried about the swallowing. And some of the big red flags are weight loss, choking episodes, someone having difficulties with chest status. But it is also other things, like if someone is dehydrated or particularly people who are cognitively not intact. Family may report that they start spitting food out, patients with dementia. So sometimes you'll see a degree of self-regulation where people realise their swallow is broken and they just avoid doing it. And certainly in the paediatric world, that's a phenomenon as well. But if we have someone who comes in with a terrible aspiration pneumonia from DEM, there are some red flags. If they're older, if they've had a stroke, if they've got a neurological disorder, certainly if they have head and neck cancer, these are all things I'll be worried about. And then with that, if I'm seeing when I actually do face-to-face with the person, if I'm noticing a constellation of cranial nerve deficits. So we're very, very focused on the cranial nerves to do with swallowing and speech. So looking at the sensation of the face, looking at how the tongue's moving, looking at how the palate's moving, indirectly listening to them. What does their voice sound like? Does their speech sound slurred? These all give us little hints that something might be amiss. And then actually obviously looking at the patient directly and looking at oral trials. And we're looking for overt signs of aspiration, so that's food and fluid going down the wrong way. But we're also trying to rule out those people that may have silent aspiration. So that's food and fluid going down the wrong way and people aren't coughing, they're not doing anything obvious. That's when nurses, particularly on my ward on neurosurgery, which is where I'm based at the moment, if they deteriorate or they become febrile, they develop a fever, these are all things that we join the dots on and we work with the team, or I'll often say to the physio, look, I tried them on some custard yesterday, how are they today? And the physio will say to me maybe, oh, they're fine, or their chest has gone off. So we have to use all those multiple sources of information. And the research suggests that if you do that well, we're pretty good at picking up the people in trouble. The people that are more challenging are the people that are silent aspirators, which I referred to before. And sometimes we need an instrumental assessment for that. So we need a video fluoroscopic swallow study, or we need a FEAS, which is not a fibre optic endoscopic evaluation of swallowing. So we can get a top-down view and actually see what's happening, or a side-on view via an X-ray. And ultimately, they are the gold standard if we're concerned about someone.
It's like pieces of a puzzle.
Yes. So it would be very tempting. You may see speech pathologists on the ward palpating someone's neck and feeling for that whole voice box changing and moving up and forward. You may see us using pulse oximetry. You may see us using a stethoscope. What we do know is there's not one tool and not one magic wand, but it's how I combine all those things. But there are some things we know now, which in recent years we understand. If someone has a severe aphasia and they have no verbal output, for example, that's someone I'm very worried about, because you know if their motor system is unable to produce speech, it's usually unable to produce a cough. So it's if someone's got a severe aphasia, then they're people that are at risk of silent aspiration as well.
Yeah. All right, so your number 3 is, why is dysphagia, and I feel like that G, we're going to just ram it home today.
No, you've got it, Liz. That's great.
Why is dysphagia dangerous?
Well, it's dangerous for the obvious reasons, which is if someone can't swallow and they obstruct their airway, that's choking. And the two things most implicated on choking in Australia with coronial inquiries is bread and sausage. So try not to think about that when you pass Bunnings on the weekend. But in serious terms, very serious implications, people can, there are issues with mortality if someone has a really severe aspiration event. And more importantly, particularly in my world, it is generally linked with morbidity and people. It is predictive of people less likely to go home. But importantly for our setting, it's now strongly linked with increased length of stay and healthcare costs. So aggressive management and very, very careful risk management from the beginning is implicated with reducing length of stay and reducing morbidity and mortality. And that's why we have lots of processes in place to screen people within the hospital.
Yeah. And we've got to be careful not to have a complacency, I think, around aspiration, don't we?
Yeah, because I think if you work in an elderly care space or a dementia space, you may be in a context where you have to accept risk. And patients may accept risk, which is what we call informed choice. That's a very different scenario, and our role in that space is very different. We have a young person that's come in with a massive stroke or hemorrhage or brainstem stroke, and if we neglect it in that situation, it's at our peril. Not that you would neglect it in any situation, but your role changes depending on the context. And there's a high incidence of dysphagia, sort of between 40 to 70% with people with a stroke. So it's an important thing that we rule out early on.
Now, excuse my ignorance, but when someone has dysphagia,
yes,
is it reversible? Is there stuff that you can actually do?
Yes, definitely. So we have a role to assess it in an accurate manner, and usually via an instrumental assessment, we will identify therapy. So some of that therapy may be direct therapy with thickened fluids or modified to get people swallowing again, because that is a good exercise for swallowing. But we can also do indirect exercises, so exercises that specifically work different muscle groups and try and actually get the swallow biomechanics to improve and to reduce symptoms. Yeah. So we have sort of a two-pronged approach.
So interesting. All right. Your number 4 is who is actually at risk of dysphagia?
So I think I touched on that with the incidence within just stroke, but what we do know is swallowing is a fairly elegantly and refined sort of system. And, we speak and we swallow with that same area. And for it to work well, it's got to happen in a timely and complete manner to protect an airway. So it doesn't take much for it to be disrupted. Certainly in the client group I look at, a stroke is enough. In an elderly person or an older person, they have age-related changes that are entirely normal. But what the research suggests now is if they come into a hospital and it can be a fractured neck of femur or it could be a UTI, that just unravels them enough and they lose their natural reserve. And then we get a very, very significant phenomena of like a dysphagia vicious cycle. So what I mean by that is they have problems eating and drinking. They start avoiding eating and drinking. That's linked with dehydration. If they're not eating enough and their nutrition is poor, then they get weaker, then their swallow gets worse, and so the cycle continues until we break it with proper assessment. We have patients that sometimes we just say you're nil by mouth and we need to feed you and make you stronger, and then we'll start again. And we've had some very good results of an elderly gentleman who came in with a fall. He just had a video fluoroscopy with me and everything was really unsafe. He had an NG feeding and exercises for about 2 months, and he is back in his independent living unit eating steak and chips.
Oh, wow.
But if we hadn't broken the cycle, that outcome would have been different.
If you're an elderly person and you know it can be just an inevitable, like as you're getting older, is there things that you can do to prevent dysphagia? Like,
in America, they have all sorts of machines you can buy as a prophylactic. You can actually do sort of like sit-ups for your chin.
oh.
And there's all sorts of resources like that. But there is some...
Is there any science behind that? Or you can
Yeah,
just
there is
buy
some
it?
science behind it. I think generally keeping fit, well, mobile, they're all good things as well to be protected.
Like variety of diet? Like do we have to keep using our jaws and...
Yeah, I think there is an element if it's not healthy for any of us to go on a puree diet. And, if you think about the standard, I think Maggie Beer produced a book, Eggs Don't Bounce, and that was very much a call to arms for not giving people in residential age facilities this generic processed food and that herbs, spices and having beautiful sensory food. And my research looks specifically at a sensory enhancement and the fact that some of the more complex compounds like gingerol or caffeine or even red wine, the compounds in that have shown evidence of actually symptom reduction in dysphagia. So it is a real thought of what people access in a residential age facility versus actually the things that might be helpful to sort of help their swallow and optimise things.
How interesting.
Yeah.
Japan is looking at fortified wines and sake that have like it's a polyphenol agent. I'm getting into my nerdy area now, but there's a new receptor they only identified in 1994 on the tongue that processes all the complex compounds like carbonation, which is what my research was about, but gingerol, wasabi.
Because I don't drink alcohol. Does that mean I'm at a risk of dysphagia?
No, but, like it's the fact that, sparkling water with a squeeze of lemon or...
I have that every day.
Or gingerol,
What's gingerol?
Like ginger beer.
Oh, yeah.
Grated ginger in your
okay.
All those things that give warmth in your mouth, capsicum, sweet chili sauce. They're all the things in Spain, the other country, they do a lot of the sensory research. They're getting really good results with capsaicinoids, which are the compound in chilies and stopping people aspirating with just having this like Dr Pepper drink. So if I had the choice when I'm 80 of thickened fluid versus
a ginger
this
ale.
cocktail of, I think most of us.
Spiced rum.
So that's which was my favourite, my father's favourite drink, and he did have dysphagia and he could swallow it easier, but my mother would roll her eyes at that.
Yeah. This is so fascinating. This is what I love about this podcast. You think you know what you're going to hear and then there's all this beautiful science about it. So your number 5 is dysphagia and the bedside nurse. Like what can people actually do at the bedside to prevent or to watch, to assess and to assist our patients?
A lot, yeah. So if you work with me on a neurosurgery ward, apologies now because you've heard me write this up on a board and tell people about it 1,000 times, but posture is important. More importantly, if someone can feed themselves in any way possible, it may actually be hand over hand with you helping the person with each spoon. They are going to be much safer. And why that is so is the neurology of grasp and holding a utensil. You are born with this very strong link between your mouth and your hand, and particularly with dementia patients, if we can get them eating and drinking by themselves, even if it's with support, it is so much better than being fed. And the research confirms that simply being dependent on someone else feeding you increases your risk of things going down the wrong way.
Wow.
And
when you say posturing, are you saying like make sure people are sitting up in a chair? Like what does that actually mean?
Well, I often say on the ward because we disable particularly older patients by them perhaps leaning back and having a slight head tilt back, which is exactly the wrong position. We want people sitting up like Queen Victoria at a dining table, head forward, like they're actually having a proper formal meal versus, and unfortunately hospital beds, it's very easy for people to slump down in the beds and, you know, they're often very unwell and fatigued. So it's getting the environment right, but then thinking, how can we get this person independently? It's different if they're very, very impulsive and they are at risk of obstructing an airway. But I think most of the time, even those people, and I work with at the moment people with severe brain injuries, and you can still help people with light hand over hand and often tactile cues or verbal cues to stop and start and to pace themselves.
If you're sitting in your car or whatever listening to this right now, have a go at tilting your head back, like say 15, 20 degrees and try and activate a swallow, and then compare that to having your chin at a neutral with a normal neck flexion. And you'll feel it immediately. I just did it while I was talking, and I'm sure I looked odd. But
yeah, I think the other things I'd add would be if you're with someone, and particularly if you're a nurse, feed each other with a blindfold or covering one eye, and try and mimic some of the deficits and sort of inattention that patients have. And it soon becomes clear why it's more of an aspiration risk, because you're missing all that pre-swallow information of your actual swallow system saying, I need to swallow now, I need to get ready.
Is there anything else apart from, you know, posturing and encouraging people to feed themselves?
I think nurses have a really, really valuable role, and on any ward, but particularly on neurosurgery or hyperacute neurogenic wards, if someone has got a large hemorrhage, by the very nature of it, it may not be over until the fat lady sings, so to speak. So they may get worse clinically. Their dysphagia will often get worse. They may have been started on a diet quite happily in ICU and they drop down to neurosurge and they're a very different person. Some of that's natural evolution of the event and the neurology behind that. But also some of that is fatigue, and the oromotor system is very fatigable. And what they manage with me at 10 o'clock in the morning may be very different to what they're managing with the nurse. So nurses have a very important role in surveillance and daily checking, particularly if they're in a hyperacute setting that I work in, because often one of the nurses will come to me and say, I know you saw them yesterday and you thought they were okay, but they're terrible today. And it doesn't need to be coughing and choking. It can just be they're now febrile and they look less well. Can you have another look at them? Just actually, if in doubt, check it out.
Yeah.
How
important are nurses in prompting referrals to speech pathologists?
Well, they're often our main gatekeeper, really. But they're also the people I'm indebted to the nurses on neurosurgery because we have got limited staffing, and one of them will ring me or page me and say, you know that guy you started on custard yesterday, can you come up and have another look? And that's what we want to hear. And that's we come in for 20 minutes, 30 minutes, 45 minutes. That doesn't replace 24-hour surveillance when someone is very dynamic and in acute recovery.
Again, maybe a dumb question, but with dysphagia, are people at more risk of aspirating like at night when they're sleeping? Like is sleep, do you have to posture them differently or be conscious of that around sleep?
Well, we all aspirate saliva when we're asleep, but when usually we still have reflexive swallows if you're healthy. You'll often see patients with severe dysphagia that nighttime becomes difficult if they're laying flat and they're not doing. So think about the normal 300 swallows we do a day to manage all of that saliva. And if you're not doing that at night, even sporadically, it's going to be uncomfortable. And so we often have people in sort of semi-upright postures particularly the people with brainstem strokes or MND, you'll often find nighttime is a difficult time because they're not managing the saliva.
Another dumb question, but I've always wanted to know this. Why is it that, swallowing saliva is so automatic until you think about it?
Mm-hmm.
Like even during this, I feel like I'm going gulp, gulp, just because all of a sudden it's on my mind.
Yeah, so you've tackled probably a topic that's a bit of a passion project for me, because I have a particular interest in getting people to do like maneuvers and strategies to reduce their symptoms. So the challenging thing with swallowing, which is different to like teaching someone a gait pattern or teaching someone to do something with their upper limb, is the neurology and the neurological control is quite different, because it is a cradle to the grave behaviour that you do automatically. As soon as we try and change it, it results in unexpected things as well. And one of the things it can do, and what we know from a cortical activation point, is if you cue a swallow, and I say swallow, swallow, swallow to you now, you'll swallow, and the pattern of swallowing you're doing will be different to just a reflex swallow. So it's the actual neurological systems involved with doing a reflex saliva swallow versus me getting someone to do a very conscious swallow are very different. And it can make people almost feel, well, the word would be dyspraxia in our world, but losing sort of coordination of it when you sort of overthink it. So it's a bit of a delicate balance with how we cue people with swallowing.
You're getting to ask all your favourite curious questions. It's awesome. And I'm just sitting back listening and going, that's cool. That's cool. Really cool.
It's one of those things, though, that I always think of, like you get tonsillitis and all of a sudden you're so conscious of your swallow, and then you think about swallowing and then it becomes laborious. But that makes complete sense, because often we've stopped swallowing with a reflex and we're conscious of it and we become a bit dysfunctional.
Yeah. So, for example, there's research to suggest if you say to someone, have small sips, that just even people who are cognitively intact, they'll say, okay, I'll have small sips, and they don't do it because they've just got that very strong pattern that they've had from the moment they were born, and they've never thought about it.
Is there anything else that is like a great take-home message for our bedside nurses?
I think the other big risk factor for developing an aspiration pneumonia that we know of is poor oral hygiene. And I think it's something that we all are responsible for, sort of making sure that someone, particularly after a meal, if they've got a facial weakness and sensory deficits. I've been to faces where they've still got breakfast in because they can't feel their face and it's lunchtime, and that in itself is an inherent risk. But also we know if the unfortunate thing when people are having real problems with swallowing, that the mouth is designed to eat and drink, and it gets very coated and very uncomfortable. So good oral hygiene and suction toothbrushes. These are really important things because you're reducing the amount of bacteria in someone's mouth and reducing the risk of an aspiration.
All right. So let me try and summarise that. So we started off, what is disordered swallowing? And essentially you said it's any sort of pathological reason where people are having trouble swallowing, and we call that dysphagia with a G. And where the thing we're reminding people about is dysphagia with a G for gut and dysphasia, S for speech. They're the differentiation. So how do you actually assess dysphagia? And you said that really it's a clinical swallow evaluation, and that it's almost like pieces of a puzzle. So we can look at people, how they're speaking, monitor their food intake. Are they choking? Are they reluctant to eat or drink? Are they pooling? Are they spitting? To the more advanced, tongue and palate movement, their voice, and then, going to actual interventions or investigations as the gold standard. Why is dysphagia dangerous? And, this is pretty self-explanatory, isn't it? It's because if people have problems with their swallow. They might have an obstruction with their airway. And so you said, like choking, aspiration, which can lead to malnutrition, dehydration, mortality, and also a number of morbidities, which have terrible implications for our patients and their families, but also mean that they're unable to go home, increased length of stay, increase of resources. So every single person needs to be really invested in this. Number 4 is who is at risk of dysphagia? And you're saying that really lots of elderly people can be at risk of this. So age is definitely a risk indicator, but 40 to 70% of people with stroke, people with acquired brain injuries, Parkinson's, head and neck cancer. It can also be a pediatric issue, but, on the whole, that there is a cohort of patients and we need to be paying attention for anyone who comes into hospital with anything that could fall into those risk categories. And your number 5 is dysphagia and the bedside nurse. And you were just saying that essentially the bedside nurse is imperative all of this because they've got this 24-hour assessment and view of eating, swallowing, drinking, vocal, etc. But some really take-home messages that are important is, number 1, posturing. It's much easier for people to actually be able to eat and drink if they're sitting upright, and you said like the Queen, and that how difficult it can be for people to actually swallow correctly if they're not postured and they're in bed. The second thing is that there's real science between people feeding themselves and the grip around cutlery and being able to swallow. So even people who are having trouble, if you can position your hand over their hand and assist them to feed themselves, can make a huge difference. You spoke about that oral management systems can fatigue, and so to be mindful what people are able to do in the morning may actually deteriorate over the course of the day. And the second was that oral hygiene has a really important part to play in all of this. So please make sure that people have assistance with brushing their teeth, washing their mouth out after food, etc., because that can all play a part in dysphagia and its level of severity or the ability to recover.
Yeah, and specific to Royal Brisbane, we do have a dysphagia screening test for that reason, because it is a big problem. And the nurses are trained here to complete that. And if people fail that test, refer on to us. So if in doubt, check it out.
Beautiful. That has been a fantastic podcast. Lisa, thank you so much for joining us today on 5 Things.
Thank you for having me.
The Royal Brisbane and Women's Hospital 5 Things Nursing podcast acknowledges the Turrbal and Yagara as the First Nations owners of the lands we now tread. We pay respect to their elders, laws, customs and creation spirits. We recognise that these lands have always been places of healing, teaching and learning. We also wish to acknowledge the First Nations people of the lands of our global community and encourage our listeners to seek out, listen and learn from the knowledge held in your shared space. As well as all major podcast outlets, you can find us at 5thingsnursing.podbean.com. Please also subscribe and give us a rating on your listening platform of choice. This helps others find the podcast. And finally, if you'd like to connect with Liz or myself on Twitter, we can be found at LizCrow2, and for me, it's inject_orange. We would absolutely love to hear your thoughts, ideas, or feedback. Thanks for listening to 5 Things.